Thank you very much. And so as I say, now for the rest of the story. So we'll talk a little bit about karyotypes in more detail and the differences between the karyotypes that are related to Turner syndrome. And we'll say this is that you're unique and not alone. So we'll see how many karyotypes we have in common as well. So I'm going to recap a little bit of lecture one, just for those of you who may be just joining us. So we'll talk first about what is a karyotype, just catch everybody up on that. Why is a karyotype important? What it can tell us about us when we have Turner syndrome, what we know and what we don't know. Sometimes what we don't know is even more important than what we do. And why it's important to better understand your karyotype or your child's karyotype for their medical care. Okay. So everybody want to join on the VVox so we can join the conversation here. And I'll give you a few minutes to sign in. Okay. So my first question here in the poll is, I like to get to know my audience a little bit, so I want to know how many of you are here as an advocate for Turner syndrome, how many of you might be a physician, or how many may have Turner syndrome or a child with Turner syndrome. So I'll let you go ahead and add in the poll there. I see still people polling in, so we'll give you a few more seconds here. All right. So, looks like we have some advocates, a lot of people who have children with Turner syndrome, people with Turner syndrome, and also a few healthcare providers, and I'm sure some who have both. All right. Now, my next question is, do you know your karyotype or your child's karyotype? How many of us with Turner syndrome or who are a parent actually know their karyotype or their child's? I'll go ahead and answer. You can say, I know when I have the report, I don't know, or I know, but I may not have seen the report, or I've never been tested. All right. So that's great. So most people do actually have their karyotype or their child's karyotype. They know what it is and are aware of it. So that's wonderful. So that means that genetic testing is really helping with diagnosis of Turner syndrome. So a little more of that recap on the genetics that we talked about in the first lecture. So we talked about the library. That's our genome is our library of genetic material. And our chromosomes are the bookshelves. And they hold our genetic material, our books. And those books make up our story, our journey. The chromosomes come in pairs, one from mom and one from dad. And in Turner syndrome, you're missing all or part of the second sex chromosome. And we talked about at the last visit, this is random, nothing that anybody does to cause this to happen, not exposures, not your parents. Nobody causes this to happen. So when is a karyotype performed for Turner syndrome? So we can do screening during pregnancy on maternal blood. This is really new, and this is helping Turner syndrome to be diagnosed early. Prenatal diagnostic karyotype can be done also by CVS and amniocentesis. So the first test is a screen. The second one actually tells us if we have Turner syndrome. We can also do the karyotype at birth for confirmation of a prenatal test that showed an increased risk on that screening, or maybe a baby shows on ultrasound something like a coarctation of the aorta or extra fluid at the neck. And we could do it later if the diagnosis is not suspected as a baby. We know that traditionally some people with Turner syndrome have been diagnosed very late, like when they don't have a menstrual cycle. So what is non-invasive prenatal testing? We're going to talk about this a little bit because it's new. So we can now take baby's chromosomes out of mom's blood and take a quick peek at them. There's no risk to the baby, and this is universally being offered by obstetricians in the US during pregnancy. But one of the important things to remember is that this is a screening test only. It does not tell us if somebody has Turner syndrome or not. I've had several babies born, and they say, well, they've had a positive screen prenatally, and I test them after, and they don't have it. There's also some children that can have a negative screen, and then we find out at birth that they have Turner syndrome. So how old were you when you or your child was diagnosed with Turner syndrome, or how old were you when the karyotype was performed, or how old was your child? So go ahead and add that in. We're going to do a word play here and see. So look at this. We see a lot at birth. I see the highest there being 15, a couple of 12. But the nice thing is it looks like many of these are very, very young. And that's really important. Many of the diagnoses are made very young, and that's new because that means that pediatricians are recognizing Turner syndrome more, but also that screening process is helping a lot too in picking up children earlier. So we'll talk a little bit more about what goes into a karyotype. So a karyotype is a metaphase spread of chromosomes on a slide. So metaphase is that point in the cell cycle. Our cells go through a cycle of cell division, and metaphase is when the chromosomes are the easiest to see, and then we drop them on a slide, actually with a dropper, right onto a slide. We use a stain called GIMSA, it's a fancy name for the stain, and that makes those bands on the chromosomes that we see in the pictures. This test counts the chromosomes. It makes sure all the chromosomes are there. It looks for switches between the chromosomes called translocations. It also looks for missing and extra pieces of the chromosomes that are big enough to see under the microscope. It can't find the really, really tiny ones, but it can find the big ones. So this is just a quick picture of just chromosomes on the slide in metaphase. So this is what it looks like when you drop those chromosomes onto the slide and put the stain on them. You see those little bands tell us where we are along the chromosomes. Those help us know if we're missing pieces or if we have extra pieces because we can line them up with a known picture. And this is the known picture that we talk about, just to give you an idea. It's a little cartoon here, as we say, of the chromosomes. So these are diagram of the average chromosomes in the bands that would be there, and you can see the X down at the far right. And this is a karyotype of somebody with Turner syndrome. So the left one is 45X. You're missing the whole X chromosome, and the second one is a partial deletion of the X. So you can see that second X is smaller. So that person has missing part of the X, and the one on the left is missing all of it. What is mosaicism? So we talked a little bit about that last time. Mosaicism is when some cells have one karyotype and some cells have another. So you can see this person here is missing the X chromosome in the cells that are pink. And the ones that are purple, they have the average standard karyotype. And this is by non-disjunction during mitosis, those later cell divisions that we talked about after conception. That's why only some cells have that. It's caused by non-disjunction. The chromosomes aren't pairing along correctly. And this is just another quick picture for those of you who were at the last lecture of the X chromosome. Remember, we have the PAR 1 and 2 regions that make up 2% of the X and 5% of the Y that allows us to pair the chromosomes. And also, those are the areas, as you'll recall, that we have to keep active in both the X and the Y, and in both copies of the X. Remember, one copy is inactivated in each cell. We talked about that in the last lecture. One of the X's is inactivated, but not entirely. We have to keep those PAR regions. So what do we know about the function of the X chromosome? We know there's the genes that are on it. We know somewhat about what they do. What is the function of the X? So one copy is turned off. It's random which one is turned off. It's controlled by the gene exist on the X chromosome. So that's the gene that's very important, and we'll talk about this when we get to ring chromosomes. That gene must be functioning properly to turn off one of the X. And this is important for those with structural abnormalities of the X. So the 45X standard Turner syndrome karyotype, we know that we're just missing one copy of exist because we're missing the whole second X chromosome. But when we have a structural change in the X, this becomes important. What do we know about the karyotypes of Turner syndrome? And this is the burning question. What makes each of these different? Can we predict different issues for somebody with one karyotype versus another? So we know that some of the chromosome karyotypes are more common than others. We know they can help to predict whether some with Turner syndrome will have a certain related medical issue. They don't always correlate with the severity of Turner syndrome. They all occur randomly. Again, they're not anything that causes it to happen. Even people with the same karyotype can be very different from each other. We have 20,000 genes altogether. So just because we have the same Turner syndrome karyotype, two people can have 45X, but all of our other genes are interacting with that. So that's why everybody's different. These are just some examples of the karyotypes with Turner syndrome. We can see at the top the 45X, that's the most common. We have mosaic 45X, 46XX, and we have some other variations on structural abnormalities such as ring and isodicentric X. We also have some karyotypes that are not Turner syndrome, and that's really, really important to know, is that there are some that we do not classify as Turner syndrome, such as deletions of the very end of the little arm and the very end of the long arm. Those can cause maybe short stature by itself or can cause ovarian insufficiency by itself, but they are not Turner syndrome. And this is a little cartoon that shows you the differences between the different karyotypes. So on the left, you see the 45X. We're missing a second copy of the sex chromosomes. You could have 46XY, where you have mosaicism for 45X cells and 46XY cells. You can also have mosaicism for 46XX and 45X. Then you have structural changes such as deletions of part of the X, and remember it has to be a significant amount of the arm, not just the end of the little arm or the end of the long arm. The ring X, and then we also have the isodicentric X. So we'll talk about 45X first, since that's the most common. It's the most common karyotype. All of the cells have the same karyotype, so it's not mosaic. More medical issues in general occur for people with the 45X karyotype because all of their cells are affected. And also, this is the highest number of individuals with Turner syndrome with regard to the risk of congenital heart disease. So the risk for congenital heart disease is highest when you have the 45X. Now the 45X, 46XX mosaicism is the next most common. And we do think that perhaps even some of the people with 45X have a little bit of mosaicism. So these individuals could be milder or have the same severity of features to 45X individuals. So just having that extra cell line of 46XX doesn't necessarily make symptoms milder, but it can. And it doesn't always correlate between the percent of cells that have 45X and how severe symptoms are. So somebody could have 50% with 45X and someone else may have 10% with 45X and have the same severity. These individuals are more likely to have spontaneous puberty and pregnancy. So the mosaic individuals are the ones that more often will have perhaps spontaneous puberty or to have a pregnancy on their own. There's fewer with left-sided heart problems like the bicuspid valve and coarctation, and obesity and hypertension are less frequent because you have that mosaic cell line of the 46XX. It makes those less frequent. And I've had some questions too about the 45X, 47XXX mosaicism. And so in this type of non-disjunction, you end up with two different cell lines, one having an extra X and one missing an X. These girls also will have milder features potentially, fewer cardiac anomalies. They still could have some developmental and learning issues and mental health challenges because individuals with all of their cells with 47XXX are at higher risk to have developmental delays or learning issues. Many of them don't develop any of that, but putting both of these together, you can have a somewhat increased chance to have those things happen. Also, we know that individuals with 47XXX can be on the taller side, so perhaps this mosaicism can also be a little bit taller for individuals with Turner syndrome. 45X, 46XY mosaicism. So this is a more common karyotype probably than we know. It does not mean that these individuals are male. All individuals with Turner syndrome are female. Even if you have a cell line that has 46XY, there's an increased risk for gonadal and that's a kind of tumor that can happen on the gonad tissue, on that ovarian / testicular tissue that can arise in the 45X, 46XY mosaicism. Fewer will have hearing loss. It seems to be lower in these individuals. And there's also a lower chance of autoimmune thyroid dysfunction. So these are some, also a group that in the new guidelines, there's a lot more recommendations about what to do for individuals who have both of these cell lines. The next one we'll talk about is one of the more rare but still frequent karyotypes. This is called isochromosome X, or also called isodicentric X. It can be called by either one. And you can see it listed two different ways in karyotypes, just depending on how that particular lab wants to denote it. These individuals will have an increased chance for autoimmune issues, a medium severity for left heart issues, so they're kind of right in the middle of the road, lower chance of coarctation, and some can have a spontaneous puberty. So similar to the mosaic patients, these can have some spontaneous puberty as well. So let's look about how isochromosomes form, and this is just a little picture of, you can see that if you have two copies of the X chromosome, we just put them in one orange and one purple, they kind of make an exchange between each other, and you end up with an isochromosome, which is two copies of the long arm, which means you're missing the short arm. So you could think about it like deleting the short arm, but then you end up with an extra copy of the long arm. And sometimes that isochromosome also can fall out later in development, and that's where you will end up with the 45X cell line along with the isochromosome sometimes. So, talking about isochromosome, we can also talk about partial deletion of the X, missing that short arm. So individuals who are missing the short arm can have variable features and medical issues. It can vary a lot depending on how much you're missing. And it also depends on whether in more of the cells, we expect about half and half, but sometimes there can be a preference for turning off the abnormal X chromosome and keeping the normal one turned on. Sometimes our bodies will skew that exist gene and cause it to keep the normal copy turned on more often. So that can also affect the features. And this is a picture of a partial deletion of the X. You can see that on the right-hand side is the deleted X, to the left is a normal. You can see you're missing a small piece. And again, the features can vary depending on how big that piece is. Ring chromosomes. Ring chromosomes are a karyotype that's more rare, and one that we really would like to know a lot more about than we do. So we talked about exist, and this is why exist is so important, because in the ring chromosome, exist can help us determine the features. So if exist still functions and you have normal inactivation of one X chromosome, there's an increased chance for metabolic syndrome, like increased weight for height, blood sugar dysregulation, but fewer have heart issues like bicuspid valve. If the exist is not functioning properly and we're not turning off one copy of the X, then there's an increased chance for neurodevelopmental and learning issues more so. So those individuals that have a higher risk for that than average individuals with Turner syndrome. So we'll go back here, sorry. So I'll put the poll open. So put in what is your child's karyotype. So those of you who know, I know the majority of you know. So you or your child's karyotype, click off which, so we'll see if it fits with what we know to be most common. So see that there's 30% have the 45X. We also have a good number with mosaicism and a good number with the isochromosome as well. So, and that fits a lot with what we know it for Turner syndrome in general. It looks like pretty much the same distribution of karyotypes. And what's really important is how many people know their karyotype. That's great. So how does knowing the karyotype affect care? Why is this important? So there can be an increased awareness of certain health issues that can occur more often with a specific karyotype, like we talked about. There are some differences. We don't know enough currently to suggest differences in healthcare evaluation and management in individuals depending on karyotype. The care guidelines still apply to everyone with Turner syndrome. So we don't know enough about the differences between the karyotypes to say, well, there's different ways to manage each one of them and we should change the guidelines specifically for each one. But we do know that there's a little different awareness that we need to have. What do we want to know? So, okay, we talked about what we do know. What do we want to know? So we want to know why a certain karyotype is associated with certain features. That can help us predict issues before they happen, like aortic dissection. We'd really like to know who's more at risk for things like that. Can this improve interventions to avoid complications? If we know who's more likely to develop issues based on their karyotype, can we change how we manage, change how we monitor? How are we learning more? So we know that we want to learn more. How are we doing that right now? Studying how the X functions, learning more about what the genes on the X chromosome do and understanding their function in Turner syndrome, better understanding the pathways in which the X genes interact, and gathering more natural history information from Turner syndrome girls and women and practitioners, so everybody participating in research. And that's such a huge, valuable part of Turner syndrome. And the TSSUS is how many people are in the research and joining us with that and helping to gather that information. And how can this help? Well, we hope one day that there will be more personalization of the healthcare plan, earlier recognition of health issues in addition to earlier diagnosis, improved treatment for complications, and in the end, hopefully better and better outcomes for patients with Turner syndrome. So how can we all help each other in addition to gathering that information? What's another big piece of pushing forward care for people with Turner syndrome and bettering the care? One is knowing your and your child's karyotype and sharing it with your doctors. Education of primary care physicians and other specialists, so engaging the entire medical community that's involved in care for Turner syndrome, making sure they know the latest guidelines, working with research registries and collaboration among researchers. So really communication and education among all the stakeholders is better for everybody, and sharing that. So what are some key takeaways or things that we need to know about karyotypes? There are different karyotypes associated with Turner syndrome. Not everyone with the same karyotype has the same features. Some medical issues are more common with certain karyotypes. And learning more can improve care for girls and women with Turner syndrome. It can make it more individualized and hopefully better. And I put up just a couple references and resources. The first one is the new consensus guidelines from the meeting in Denmark last year. There'll be a patient-friendly version of that coming up eventually on the Turner Syndrome Society of the US website. And the second is an article where by Dr. Lin and collaborators about transition to adult care in Turner syndrome and what's important in advocating for yourself as an adult and what are the important things to know in Turner syndrome care as an adult. So that can be a good resource too in talking for adult women with Turner syndrome, talking with their doctor. So please use the chat feature in the VVox for questions like in the last lecture. So go ahead and type in questions. I'm glad to take them, and we've got plenty of time for questions. So that's a great question. There's the thought, and there's not great data, but there's a thought that many, we talked a little bit in the last lecture about at conception, it's thought that about 1 in 50, there's about a 1 in 50 chance at conception for Turner syndrome, but then 1 in 2,500 at birth. So that means that a large number experience miscarriage and don't make it to live births. So they've said upwards of like 95% is what's quoted, but there's not been really good systematic study for it. Sure. Okay. 98%. Yeah, so there's varying, that's the thing, it's because it hasn't been statistically really studied in detail, there's been sort of a lot of conjecture, a lot of guessing, but they're all pretty close, 95 to 98. So I'm glad that you enjoyed the information. So let's see. Are there cases when a mosaic individual with Y cells has male features or ambiguous features? So that can happen, yes. There are individuals with 45X, 46XY karyotypes, but if they have male features, they're not diagnosed with Turner syndrome. So we may monitor them medically in the same way, but they're not given a diagnosis of Turner syndrome. Yes? Mm-hmm.
And any tips for initiating a conversation with primary care?
Right. So that's a really good question. I think the first key is having a primary care physician that you feel comfortable talking to, that you feel you can voice concerns with in general. And then there's some really good tools on the Turner Syndrome Society website that you can use that talk about guidelines at different ages. But also one helpful thing can be to write down some of your concerns before going to the primary care doctor. When you know that you're going to have your visit, write down some of those concerns or things that you know can happen with Turner syndrome that they may not be aware of, but that you want to address, and take that with you, and just having that conversation. But those can be some good starting points, is kind of writing down some of your questions, but also grabbing some of those tools from the Turner syndrome website as well that you could take with you. So, how can a doctor tell what kind of Turner syndrome do you have? And so that's by doing karyotype, which is that blood test that looks at your chromosomes. And that's usually the most common test. There are some other tests that can also pick up Turner syndrome, but if you're concerned that you might have Turner syndrome, for instance, or if you haven't been tested, the karyotype would be the appropriate test. Current research on SRY gene and Turner syndrome. So there's research going on about incidence of gonadaloblastoma and having that Y material. Not that I'm aware of, more specifically to the SRY gene. Now, the SRY gene is involved, as we talked about in the last lecture, primarily with male development. So that's a good question. I'm not aware of anything specific at the moment. Is it known if isochromosome X happens during meiosis or mitosis? So that's can be one of two ways. So if all of the cells have an isochromosome, then it happened during meiosis. Oftentimes that will happen, and then that isochromosome will fall out in mitosis. So if you have a 45X cell line and an isochromosome cell line, that isochromosome has fallen out. But generally that'll first happen during meiosis. How can I find out more about the status of exist for my loved one's ring X? Is it not mentioned in the karyotype? So they don't. Now, that being said, that talking with the geneticist, just in general, talking with the geneticist about whether that gene is included in the ring, for instance, can be helpful, but also there are tests that they can do called X inactivation tests, and they can tell if there's skewing of the X inactivation, but that would also tell us if all of the X is activated as well. So an X inactivation test could also be potentially done. Where on the X chromosome is the SHOX gene? So it's on the short arm of the X. It's kind of a little bit, right in the middle of the short arm, but it's on the short arm of the X rather than the long arm. I heard something recently that men can have Turner syndrome. Can you explain? So the current guidelines, updated in 2024, we know that, we've talked about the 45X, 46XY karyotype can happen in males, but they would not be considered to have Turner syndrome. They would be considered to be males with a 45X cell line. So only females have Turner syndrome. But those males with the 45X cell line can develop some of the same medical problems, like the heart problems, smaller growth, things like that, that people with Turner syndrome can have, but they would not be diagnosed with Turner syndrome. Why isn't there a genetic test for all children at birth? So that's a great question as well, and that may come at some time. They are pretty much screening everybody during pregnancy. The majority of women, at least here in the United States, are offered that blood screening test during pregnancy to screen for Turner syndrome. So that's even coming earlier than newborn screening because you're looking during pregnancy. So that's really increasing the early pickup. But newborn screening could be helpful, again, for those that weren't tested during pregnancy or might have had a negative test. That can also be helpful. What's the next step after you know your karyotype? So once you're diagnosed, the next best step is really getting to all the best specialists that know and are well informed about Turner syndrome. So some of the things we talked about in the Genetics Beyond the Basics lecture was having the advocate, so being an advocate for yourself or advocate for your child. Also having your quarterback in your team, which is your primary care or your care coordinator, who often is either genetics, endocrine, or your primary care, having that good healthcare team, looking for all of those things we need to monitor in Turner syndrome. So finding both of those pieces, the advocate piece and your team with your quarterback, is the most important. Is there an official diagnosis for males that have a similar karyotype as Turner syndrome? So that again would be, we would say it's a male who happens to have a 45X cell line, is what we would, is the diagnosis that we would give. Several young people we know with Turner syndrome identify as men and have undergone transgender changes. Any understanding of this being common? So that's a really great question. I don't think there's been any research on that. I think just, knowing in the news and just being aware of social media lately, it does seem like that is happening more commonly just in general in the world. So hard to say if there's a correlation with Turner syndrome, but that's a really good question. And there is data being captured about that in the Turner syndrome registry as well. That's something that they're looking at to see if there's correlations. What's the difference between Fragile X and Turner syndrome? So Fragile X is located on the X chromosome, and that causes a condition called Fragile X syndrome. The gene FMR1 is on the long arm of the X chromosome. You have to have a change in that gene, so different from missing the gene. Missing the gene doesn't cause you to have Fragile X. So people with Turner syndrome don't have Fragile X specifically, but if you have a mutation in that gene, and it's a special kind of mutation where it makes the gene bigger. It's like the story had a burp and it kept going, and made the book this big instead of this big. And in that case, then an individual can have Fragile X, but you have to have a mutation in that gene. And if you have, for instance, a mom that's a carrier, then they can have children with Fragile X, but it's separate from Turner syndrome. So it has to do with that one gene rather than a structural problem with the X. Is there a genetic karyotype associated with responders to growth hormone? That would be a really, really good thing to do research on, and there may be people out there who are doing that. And the importance of that is, one, to find are there different medications that certain karyotypes respond to better. For instance, one version of the growth hormone versus another. It's a little hard to sort out too, because you also would have to correlate for when the growth hormone was started. But that's a really, really good thing to look at to see, can that be something more personalized? But at the moment, there's not a specific karyotype that seems to respond better than another, as far as my knowledge. But the endocrinologist may have more information on that. Is it possible for a mosaic Turner syndrome woman to give birth to a female without Turner syndrome? Yes, it is, and that can happen. And it has happened. We don't know all of the statistics on how frequently, if somebody with Turner syndrome does become spontaneously pregnant or pregnant with assisted reproductive technology but using their own eggs, what the likelihood is to have an abnormal karyotype versus normal karyotype. And so it can be a normal 46X karyotype. It can also be a Turner syndrome karyotype, but we don't know how likely those are to happen. Does 46X isodicentric Y combine reported complications? So that is a really good question. It's a very rare combination. The main thing we think about when there is a karyotype that has Y material is that risk for gonadoblastoma. So when there's that Y material there, then there's a conversation about that. And there's some guidelines for that risk and whether to remove the gonadal tissue to avoid that risk. So that again would be a time when that would need to be addressed. Yes. Right. 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 Mm-hmm. Right, right. Right, exactly. And that's a really good question. That's something that came up a lot in our guidelines conference. And so we know that, we said there's differences between when we say genotype, which is what we see in the karyotype, and phenotype, which is what we see clinically, right? So part of the way we make a diagnosis is in the karyotype, but also looking at ovarian insufficiency, short stature, heart problems, putting all of those things together. And one of those pieces that is in the diagnosis of Turner syndrome is at birth, whether you have a male or female phenotype that we see. So if you have a female phenotype, then you have the diagnosis of Turner syndrome. But if you have a male phenotype, then they give you a diagnosis of 45X, 46XY karyotype. And so that's where it's a little bit different. But like you said, the genotype and phenotype, and we put those two pieces together. And that's just according to the guidelines that we have, because it's important to be consistent for everybody. So I was diagnosed with Turner syndrome shortly after birth. I'm in my 30s. Any advantages of getting my karyotype redone? And so that's a good question. It depends really on how clear your karyotype was. If you're in your 30s, then karyotype was very standard at that time, should have been using standard technology. So if it was a clear result, just talking in general, if you had a clear result for your karyotype, probably not a lot of benefit to then have to repeat it, unless you're looking for something specific that's different. Maybe is there some piece of phenotype that doesn't fit with Turner syndrome, or is there something that's changed in your health? The other thing is that as we get older, especially women as they get towards their 50s, for instance, 40s and 50s, they can start to lose the second sex chromosome. So if you're mosaic, for instance, and you have 46XX, 45X, you may find that you have a higher percentage of 45X cells as you get older, and that's a normal thing. Even in the general population, we lose that second X in mitosis more often as we get older, particularly in the blood. Yes? So that's a great question. What in that case, that's a conversation to have with a geneticist or endocrinologist or your primary care. Say, hey, if I don't have my karyotype, I really would like to know what it is. I know I have Turner syndrome. My parents told me I did, and I'd really like to know what my karyotype is for my own health care. That's a very reasonable question, and to do that if you don't know your karyotype and you want to know. Because again, as we're learning more, it may in the end affect healthcare for you. Is there a link between delayed speech in children and Turner syndrome? Yes, Turner syndrome, children with Turner syndrome can have some developmental delays or some differences and challenges in learning, usually not severe, and usually have normal cognition and generally normal development, but there can be some delays and differences. And it's one thing that Dr. Mooney talks in a lot more detail about and has a lot of really good information from his years of experience with Turner syndrome, but that can happen. It's also a good reason to check hearing. We know that a lot of people with Turner syndrome have hearing loss. And so even little ones can have hearing loss, and that can delay speech too. So in children with Turner syndrome, especially if you're seeing a speech delay, that's a good time to recheck the audiology test as well. All right, well, it's been a pleasure to be here and talk with you about genetics, and I'll be around the conference for a bit, so if you have any questions for me, feel free to grab me, and we can touch base. Take care. Oh,